Okay, I'm going to go ahead and start. I just want to thank you all for joining us. It's been a few months since we had our last webinar, so I felt it was time to reach out again, see if we can talk about some new topics that we hadn't touched on in the past. Just a few logistical things. We are going to try to do some question and answering at the end. It is a large group tonight, so we may not be able to answer all of them, and probably we aren't going to be able to. But at the end, there will be a reminder that if we don't answer your question, to please forward your questions to us at info@meditrust.com. And I promise you, I will try my best to get back to all of you. Another issue is there is a chat icon on the Zoom. Do not use that. We will not be checking that. Any questions and answers need to be in the Q&A section. So with that being said, I would like to go ahead and start. I am very pleased to have one of our clinical specialists join me tonight. Kim Prislak, who is the Director of Clinical Services in our New York office, will be joining me in this presentation. I'm thrilled to have another voice. And many of you probably have met Kim in the New York and Westchester office. So with that being said, I'm going to go ahead and remove my face from this and get the webinar started. Okay, so we're going to talk today about oral medications for female hair loss, things that have been used in the past, things that have been used in the future, hopefully, and what we're doing today. Okay, again, just hello and a welcome from myself. I'm Dr. Mary Wendell. I'm the National Medical Director for MediTrust, and we have many offices throughout the eastern part of the country, and Kim is one of our clinical specialists and Director of Clinical Services in New York. I'm really happy to have her here tonight. Again, this is just a webinar. It's only informational. Obviously, before starting any of these medications, you want to have a full evaluation with a licensed practitioner who really has some interest and specialty in hair loss to determine what the appropriate treatment plan is for you. These medications aren't for everybody, but for those people who can take them, they can be helpful in these different situations. Just quickly, our outline, we will be talking about medications that have been used for quite a long time, Spironolactone, Finasteride, and oral birth control. And this is primarily for androgenic and also some other diagnoses, which we'll talk about. All of those medications are used still today, but they have been around for decades and have been used from a variety of practitioners for hair loss. Nowadays, some newer things that have come up, oral minoxidil, which is really a hot topic right now. And Kim is actually going to walk us through the latest information on oral minoxidil, its benefits, its side effects, and who we think it will work best for. Dutasteride is a newer version of finasteride. I will be talking about that. And a few other hormonal issues can be covered with new medications. Well, they're not new, but used for this purpose. Bicalutamide, flutamide are medications that have been around for a while, but not necessarily used for hair loss. I want to briefly talk about scarring alopecia and alopecia areata. I'm sure we have some patients on this webinar who are experiencing both of those types of hair loss. And I want to update them on the latest medications. Lastly, briefly, just some new testosterone blockers I'm going to talk about. I'm going to do a quick review. Those of you who've been with us in the past on webinars have probably seen this slide more than once, but for new people, and just as a nice reminder, even for myself, the hair cycle has 3 stages. The anagen cycle is the growth stage. It lasts anywhere from 2 to 6 years. And in fact, in little girls who can grow their hair down to their knees, it probably even lasts longer than that. Unfortunately, the anagen cycle decreases as we age. And with a lot of these issues with hair loss, they shorten even further. Catagen is when the hair starts to pull away from the follicle. And then the telogen is the shedding phase. And then it goes into a resting phase where nothing grows for several months. And that oftentimes is a time of concern for a lot of women who are going through hair loss. We want to shorten that telogen phase. We want to lengthen the anagen phase. And that's where a lot of treatment comes in. Okay, two types of female hair loss: non-scarring alopecias, which are the most common and what we see the most here and in most clinics. The androgenic alopecia is also known as female pattern hair loss. Telogen effluvium is excessive shedding. Traction alopecia is hair loss as a result of pulling and tugging on the hair to style it. It's most commonly seen with thinning along the frontal hairline and the temples. Alopecia areata is when people develop spots of hair loss that tend to be circular and very sharp edges, but it can progress to total loss, which is devastating, of course. And then post-cancer hair loss, which is as a result of both chemotherapy and radiation therapy, can cause really permanent loss. Even after there's some regrowth, it may not regrow to the full extent that it had been before. And then there's scarring alopecias, which are less common, but unfortunately we're seeing more and more of them. And this is an inflammatory condition, which is often autoimmune, where the hair follicles are actually destroyed, which is very aggressive at times. It can cause scarring of the hair follicles and permanent hair loss. So with that in mind, how's the best way to treat hair loss? And we stress this because we see so many women who have gone to other practitioners who really didn't have an expertise in this. And it's important to get that full medical history, to get the full hair loss history, do a careful examination of the scalp with the trichoscopy, which is a magnification. And oftentimes we will do blood work. Biopsy is, we don't do it that often, but if there's any question about loss, if there's any likelihood of scarring alopecia, or we're uncertain of the diagnosis, we will do a biopsy, which is just a small area that's easily removed to give us the full diagnosis. Now, the other issue to remember is treatment varies significantly, determined by the diagnosis of the cause of the loss. It's so different. So if you don't get the correct diagnosis, you're not going to get the correct treatment. So past treatments, I'm going to talk about these three. They've been around for decades, and some of you may have heard of them before. Spironolactone, Finasteride, and then oral birth control or hormones. And again, these have been around for decades, not necessarily focused on hair, although again, even with hair loss, dermatologists and hair loss specialists have been using these medications for this purpose for a long time. So what is spironolactone? Spironolactone is actually a diuretic that in most medical clinics is normally used for fluid buildup in the body, whether it's in the abdomen due to liver disease at the extremities, but it's also used sometimes for mild hypertension. It's known to have anti-androgenic effects, which is, again, anti-testosterone type effects by blocking those androgen receptors, and it actually also inhibits further production of these androgens or testosterones by the ovary. We do know that androgenic alopecia, which again is female pattern hair loss, is thought to be at least partially caused by testosterone and then its byproduct DHT. And spironolactone can decrease these negative effects on the hair. There's been a lot of debate over the decades as to whether, particularly with women, testosterone really plays a role. But as we will show you that these medications do make a difference. So there absolutely is some element of testosterone and androgenic effects for female hair loss as well. So does spironolactone work? And the answer is yes. In this particular study, which is recent, it was just this year in a clinical cosmetic investigations of dermatology, they reviewed the safety and efficacy of oral and topical spironolactone in hundreds of studies. They actually did a review of hundreds of previous studies and really were able to pick out the best studies, the most scientifically run studies. And what they found was after 12 months of treatment, there was a significant improvement in women taking oral spironolactone, particularly in doses between 100 and 200 milligrams, which is really where we use this medication. I did primary care for many years, and we used spironolactone for fluid buildup and for high blood pressure, and those doses were significantly less. 25 to 50 milligrams is really what we used in those circumstances. This is higher. It's 100 to 200. So it really needs to be a higher dose to get these kinds of benefits. So does it work topically as well? It probably does, but probably not as well. it does need to get absorbed, and there can be other issues affecting it. But again, they are studying the topical spironolactone. I know it is available in some clinics, but the evidence for it is not nearly as strong as the oral. What are some of the side effects? I've listed them here. In reality, fewer than 4% of women stop the medication due to these side effects. And the most common side effects that can cause significant problems is some lightheadedness. If someone has issues with hypertension, they're already on other medications. Spironolactone can increase the potassium level in your bloodstreams. It's rare, but I have seen it. It can cause some hormonal irregularities in young women. Again, these are very unlikely to happen, and when they do, they're usually mild and don't cause the women to stop. So again, fewer than 4% of women stop the medication due to these side effects, and there tends to be sort of a you get used to it. Your body adjusts to having it there, and so these effects don't seem to be as strong as time goes on. So Finasteride is a medication that's been used for quite a long time for men for hair loss, for androgenic alopecia. It's in a category of medications called 5-alpha reductase inhibitor, and it blocks the conversion of testosterone to DHT, which again is that chemical which actually attacks the hair follicle, causes it to shrink, and makes the hair really get quite thin. This medication works great in men. There are not a lot of studies in women, although I did find a fair number more recently. But again, the problem with the Finasteride in women is that if taken when pregnant, it can have significant fetal abnormalities if a woman is pregnant with a male baby. So people tend to avoid it in women, but again, in postmenopausal women, or if a woman who has had a hysterectomy or has had a tubal ligation and the likelihood of pregnancy is pretty much zero, it can be used safely in these instances. The mechanism of how it works in women is not completely clear. Again, is it totally the hormonal blockage, or is there something else? It's probably a combination. So does it help? Well, the initial studies said it didn't, because in men, they take 1 milligram and they get great results. So women were tried with 1 milligram and it really didn't do anything. This gentleman did review, in this particular study, he reviewed all the studies that he could find that were good studies, scientifically properly done studies, using between 1 and 5 milligrams in women. And again, no benefit at 1 milligram. It started to show some benefit of 2.5 milligrams daily, with the best results at 5 milligrams. And for women who took 5 milligrams, up to 93% of patients they themselves felt that they had improvement. The measurements actually showed that there was on average an 18% increase in hair density with a 9.4% increase in hair diameter. So that's a significant improvement. So what are the side effects of Finasteride? And again, the more we use this medication in women, the more likely we're going to start seeing some side effects. But again, are they significant enough to stop it? And for most women, no. The answer is no. They don't create enough problem for us to avoid it completely. We have to be selective, like any medication that you take orally. We as clinicians need to be selective as to who we give it to, and really screen for those people who might be at risk for complications. So the most commonly reported side effects from Finasteride are headache, some irregularity of menses, but again, unless someone has had a tubal ligation, I don't use it for women who are still getting their periods. Sometimes there's some dizziness, increased body hair reported. I've never seen that. Decreased libido can happen just like it can with men. The more important potential side effect is some increase in liver enzymes. And so there's been more evidence to show that there may be some evidence of some liver dysfunction in patients who have underlying liver disease. So anybody who has some underlying liver disease should not be put on Finasteride. And again, I stress this, in my opinion, should only be used in women with 0% chance of pregnancy due to fetal abnormalities. And I'm pretty strict about that. Topical Finasteride, again, I'm not going to spend much time on topical, but it probably does work. There is some benefit to it. And again, topically can cause some pruritus and irritation, but in general, it does probably add some benefit to minoxidil when used in combination. Okay, hormones. When I'm talking about hormones, I'm talking about birth control pills. And for a woman up to the age of 50, really, can take oral birth controls relatively safely. Again, we screen as women get older for issues with blood clots. If there's a family history, a strong family history of blood clots, we wouldn't consider them. But for most women, they're safe. So birth control pills have two types of hormones. They have an estrogen component and a progesterone component. The estrogen components are fairly consistent. They don't change much, but the doses do vary, and side effects can be affected by those doses. However, the progesterone component is extremely variable. There are several different types, and they can have varying degrees of androgenic activity. And there are some progesterone components that actually can block that androgenic activity, which is something we look at very closely. So oral contraceptives have been used for decades to treat conditions of excess androgenic activity, particularly women who have what's called PCOS or polycystic ovary syndrome, where they actually have too much testosterone. And there are a variety of other hormonal problems that can cause excess testosterone. And so those endocrinologists have used oral contraceptives for those women for quite some time. There is a bit of a debate out there. It's been ongoing for quite a long time, whether or not using a low androgenic birth control is better than a higher one. But in general, I strongly recommend a lower androgenic birth control with women who are premenopausal with androgenic alopecia. I do strongly recommend them in young women, particularly young women who are younger than 30 and even really younger than 40, who have aggressive early onset of androgenic alopecia. I believe hormonal therapy is indicated. And there are hundreds of different types of birth control now. Here I've listed the androgenic activity of different progesterones. I tend to go with the low androgenic. Sometimes if there's other issues, we may stick to medium, but I will never use the top group in someone who has androgenic alopecia. Okay, I'm going to pass this on to Kim. She's going to talk about oral minoxidil, which is a really hot topic. We've been using topical minoxidil for decades, and recently oral minoxidil came back on the scene, but we're talking about low-level oral minoxidil. So I'm going to hand this over to Kim, and when she's done, we'll move on to other meds.
Oh, thank you, Dr. Wendell. Today I'm going to be presenting oral minoxidil. A little history about minoxidil. As you can see, the chemical makeup is the first line. I won't try to say that in one sentence, but basically it was patented in 1969 for hypertension. The patent actually, it was used at high doses, 40 to almost 80. In 1978, there was a report that actually reversed male pattern hair loss. After that, a patent was then obtained by Upjohn and the advent of minoxidil or topical Rogaine. Good. Next slide.
Kim, can you try and get it to go? I can't, it's not moving for me.
I don't have a...
Uh-oh. Let me just check. Hold on a second. Oh, there we go.
So how does minoxidil work? Its mechanism of action. This has been studied extensively. Initially, we know that as a vasodilator, it's used in hypertension at higher doses, but at low doses, it actually improves oxygenation and nutrient delivery. In the hair cycle, what we know is shortens the telogen phase and prolongs the anagen phase. And that's what's so important. It reduces inflammation and also works on stimulating some of the growth factors and signals some of these significant pathways to promote anagen growth. That being said, oral minoxidil, the past, I think, 2 years, it's been studied extensively in combination with topical in the treatment of traction alopecia, which has an inflammatory component. And using oral minoxidil in patients like this is so important to get that the anti-inflammatory response that minoxidil can have. There's been a lot of studies with efficacy looking back and actually safety, of course, because that's paramount to all of us in the hair loss field. I found the key findings amongst all of the peer-reviewed studies is that actually it increases scalp hair growth, it decreases shedding, and showed it in clinical improvement in about 50% of patients and stabilized about 40% of patients. So who should we put oral minoxidil? What's our patient profile? One of the things that is important is topical minoxidil can create a dermatitis. The vehicle that it's in, particularly the solutions, can cause significant irritation or inflammation. Those are patients that I would definitely put on an oral form. A poor response to topical minoxidil. What happens, minoxidil on the scalp, is it has to be actually put into the active form, which is called minoxidil sulfate, a sulfate derivative. So what has to happen is this transference to the active formulation. Now that may not occur in some people. So some women, particularly who use topical and they say they've had no response, some of the things is, did they use it long enough? Are they using it appropriately? And do they have the mechanism of, transferring this to the active form of minoxidil? Some people prefer a daily oral dose and versus a topical application. This is something that I deal with all the time, is when you're styling your hair, using a topical can create havoc for sure. And I think that, this is really more of a personal issue for sure, but I love consistency. For me, a patient that's consistent is going to have better outcomes. Whether it's oral or topical, I will work with each patient individually when it comes to this. For sure, no cardiovascular or kidney disease. These are things that we look at, in every history of every patient that walks through that door. It's so important to make sure that, we're not pushing the, there is always going to be benefit and risk ratios here. So again, anyone with cardiovascular kidney disease, I would probably defer this. And also drug interactions, which we can talk about. Oral minoxidil has been really used in a lot of different conditions. Androgenic alopecia, chronic telogen effluvium. We're going to put that hair into the growth phase. Traction alopecia we talked about. It's important in scarring alopecia because you have an opportunity of getting your hair back in a short period of time. And I truly believe that oral minoxidil can reach a steady state and a good level in the bloodstream for a good amount of time and really triggering that hair to come back. Alopecia areata, and definitely in the post-chemotherapy alopecias. Now, what is the dosing? For males, I'm just going to up front and just say, basically, they start at a half, which is 1.25. In the US, we only have the tablet at 2.5 milligrams. They can be compounded into different formulations, but in the US, that's about the dose that we get across the board. Now, when it comes to men, it's usually started at the 2.5, but can rapidly escalate to the 5 milligrams. For females, which is our focus here today, we can start at 0.25 and we can max it at a dose of 2.5 milligrams per day. Now, dosing, one thing that I look at is I look at the woman themselves, their height, their weight. Do they sometimes, women can have lower blood pressures than men, particularly when they're younger. Are they on medications like Spironolactone? Those are things that I take into consideration when dosing minoxidil, just because it can have a little bit of a, blood pressure component. Although studies have really shown a very great safety profile. So again, I feel that we are learning every day about oral minoxidil. I feel that the profiles can really, blend itself to particularly consistency in females. I like to start very low and then see the profile and how the patient reacts and then go up slowly. And I think that that is the safest way of administration. Adverse or potential side effects of oral minoxidil. I like to make it easy, so I made up this mnemonic, basically hair, headaches, ankle edema, or what I like to say peripheral edema. Some people will feel that their hands are more swollen or their ankles are more swollen. Increased hair on the face. This is hypertrichosis. This can happen at higher doses. In our practice, I've not seen a lot of hair unless it's, doses greater than 2.5. Rashes and urticaria, that's a common reaction to any form of medication. Whenever we are looking at a safety profile of a medication, I like to look at the side effects. I like to give you numbers that kind of puts things in perspective. This was a recent study performed on 1,400 patients, and this was a multi-center study. It really allowed us to really say, is minoxidil safe? 20% of patients did experience some adverse effects, but only 1% required withdrawal. Most common reason for withdrawal is hypertrichosis at 15%. Now, a lot of times when the patients did have this hypertrichosis, laser or microblading and ways of eliminating the hair was performed because they felt that if they're growing hair on their face, then they're most likely growing hair on their scalp. So they were, even though 15% was high, it wasn't a reason for withdrawal. Some of the adverse effects that can happen systemically, things like lightheadedness, 1.7%, fluid retention, and 1.3%, some tachycardias, headache, and periorbital edema, and a very low rate of insomnia. But again, most of them did not require withdrawal. And I feel that making you aware of these effects initially can help us dose too. If you have a side effect, let's say at a dose of 1.25, you can reduce that dose to half and still get the same benefits of taking oral, minoxidil. Now, I wanted to go over this a little bit because I get a lot of questions about the dread shed, okay? And this is when initiating minoxidil. So shedding occurs usually in the first 4 to 6 weeks of starting minoxidil, whether it's topical or oral. And we call this in medical terms, intermediate telogen release. And this is not to be confused with the shedding that happens when people incorrectly stop using oral minoxidil. One must never stop treatment, or else the new hair that you have grown will be shed and all benefits will be lost. This is so important. I think I talk about this every day of my life, but the dread shed is frightening to some, but actually can be very mild for most. And I talk a lot of patients through this period. So I just wanted to put it out there, a little understanding of what this shedding is and what to expect. When we look closely at females with AGA, we do see a higher than normal proportion of hairs in that shedding phase, or what we call the telogen phase. And I'd like to put it simple. These hairs are waiting their turn to shed. Hairs generally need to wait in line 2 to 3 months before they shed. That's just a rule of nature. Minoxidil, when taken, sends a signal to the hairs that are waiting in line. They're saying, hey, you can now, jump in front of the line. The mandatory waiting period is over. It's waived, and the hair will shed. What is meant by this is that these hairs are destined to come out anyways. I always say, out with the bad, in with the good. And that's what minoxidil will do. Instead of coming out tomorrow, the hair can come out today. Instead of coming out 2 weeks from today, it can come out tomorrow. Instead of coming out in 4 weeks, it can come out in 1 week. But usually the shed is 4 to 6 weeks. And then your hair can start to be robust and get into anagen phase. Pros and cons. Oral, I like oral a lot. I think it's phenomenal. It's great. It's something that we can be consistent with. I always believe in order to perform a habit, you have to pair it up with a habit. Most people will take oral medications, take supplements. If they can pair an oral medication with a supplement, there's, increased obvious, compliance. And that's what's important for me. Again, patients that haven't had good response to topical, I do believe oral is definitely an avenue. Oral cons, I think that it's, unfortunately, most likely you can get some hair on the face for sure, but not at low doses, and where I feel that we can really manage these patients without having excessive hair. One of the things I wanted to point out here, and this is very important in the realm of minoxidil, I don't use minoxidil as first-line treatment, particularly oral. Topical, in in the world is used, but I don't like it to use it as a first line. To me, I like what's called the inside-outside approach. Minoxidil can stimulate, support that hair growth, but I also do believe in outside stimulation. Low light laser therapy, PRP, are phenomenal adjunct, and they work synergistically so well together. And that I think is a great approach. It's inside outside. We do have to kind of look at that in individually with each patient.
Thank you so much, Kim. I can't stress enough what you just said, which is that, this is not a magic pill that you just take once a day and your hair worries will go away. This is really part of a treatment plan. And we do know from our many, many years of experience, and this is almost our 8th year of being Meditress, although I've been doing this for longer. We do know from our own experience, and research has supported that additive treatments result in better results. So again, thank you for mentioning that. It is a combination therapy to be utilized in conjunction with other treatments. So thank you so much, Kim. I really appreciate it. That was great. So let me just talk a little bit quickly about Dutasteride. It's a more updated, modern version of Finasteride. I personally haven't gotten to a point where I'm prescribing it in women yet, although I'm giving it more consideration. It is a newer generation of that 5-alpha reductase inhibitor. It is almost 100 times more effective at blocking that enzyme and decreasing the DHT than the Finasteride is. In men, there are many, many studies in men, because again, these medications have been used for a long time in men. It is actually 2.5 times more effective than Finasteride in regrowing hair. Again, much like I had mentioned before with Finasteride, there are limited studies with Dutasteride with women. More and more of them are happening now, which is helpful. It will further clarify for us the dosing. Do we need to increase the dose as we did with Finasteride? Will we need to do that with Dutasteride as well? Most likely, yes, but this is just so much more effective. I don't know. It'll be interesting to see what the studies show. Again, a few reported cases, studies in women have shown better benefit over Finasteride, but they're early studies and further need to be done. And I look forward to those results. I'm just going to talk a little bit about these two medications, bicalutamide and flutamide. I hear about them at conferences. I don't actually prescribe them, but I thought some of you women are very educated on this topic and may have heard about them. Both of these medications are used off-label, which means that they're not indicated for hair loss in women. This is primarily just for androgenic alopecia, not the other types of hair loss we talked about. It's a hormonal treatment, and it's primarily in postmenopausal women. Both of these medications are actually FDA approved to treat prostate cancer in men. They're both very potent anti-androgen drugs. And recent studies of about 400 patients did show significant improvement in women. However, most of these patients were also being treated with other things such as oral minoxidil, Finasteride or Dutasteride, and Spironolactone. So the studies weren't perfect in terms of elucidating whether these medications should be considered, and certainly not considered alone. The problems with these medications, they're very potent anti-androgen medications, but they also tend to have more side effects, which is why I don't use them. Actually, flutamide is not even available to be used. It is available, but nobody uses it for this because of the high level of liver toxicity. The bicalutamide also has concerns with elevation of liver enzymes, can cause some fluid retention, some menstrual irregularities, enlargement of breast tissue. Again, these are all your hormonal side effects, which we've heard from other medications as well. But again, because of the risk of liver inflammation, you have to follow blood tests and have them done before even starting, and then follow them every 3 to 6 months after. cannot be used in premenopausal women with any likelihood of pregnancy. Again, some of the same concerns that we mentioned before. My recommendation with these medications is to use with extreme caution, and really only in women who have failed pretty much everything else. And I've seen women who have failed, and we don't know why they do. Fortunately, more than 95% of women that we see with androgenic alopecia will get benefit from our treatments. Every so often someone comes through and we're just scratching our heads wondering why, and have done an extensive evaluation and even worked with their primary doctors to try and figure it out. That would be the only patient that I would even consider it. And even then I would give it a lot of thought before moving forward. I just want to talk about, I think there probably are some women listening who have scarring alopecia. When we first opened up 8 years ago, we rarely saw scarring alopecia. It's an entity that is considered an autoimmune disorder. It's inflammatory. It can result in progressive and permanent hair loss. You may have heard some of these terms: frontal fibrosing alopecia, or FFA, lichen planopilaris, LPP, central centrifugal cicatricial alopecia, which is a mouthful, CCCA. We don't know what causes these things. There's a lot of speculation. There's a question whether cosmetics are playing a role. Are some of the chemicals that we're exposed to and all of the cosmetics, even some shampoos and facial creams, is any of that playing a role? Are we being sensitized to all of these chemicals, and is it, resulting in some sensitivity in our scalp so that it's causing hair loss? We don't know. We don't know what the causes really are, which is incredibly frustrating because the incidence is increasing. We are seeing it increasing significantly over the last 5 years. With COVID, it has increased significantly. We do know that COVID has an incredible immune response when people get sick with it. And we're seeing shedding, which is more like a telogen effluvium, but we're also seeing more scarring alopecias. So it's becoming more common. We're seeing more and more women coming through. And so I think it's worth talking about, even though it's not the most common type of hair loss. We're probably pushing almost 10% of our patients. It used to be we would see somebody, once every couple of weeks, do a biopsy. Now we're seeing them almost every day. It's really, for me, it's troubling, and treatment is challenging. So let's just talk about it just for a few minutes. Typically, topical treatments like steroid solutions like clobetasol and injections are primarily used. They were certainly the mainstay of therapy for a long time to stop the immune response and decrease the inflammation. And they are still used, but now there are several oral medications which are also being used. I previously discussed both Finasteride and Dutasteride, which are sometimes used, particularly with frontal fibrosing alopecia and the CCCA. Low-dose oral minoxidil plays a role here. This is, as Kim mentioned, we can use oral minoxidil in virtually every entity of hair loss that we see. It's often used in conjunction with other meds, which I'm going to just touch on briefly. Something called low-dose naltrexone, hydroxychloroquine, doxycycline, and prednisone. Low-dose naltrexone is actually, the scientific phrase is it's an antagonist of opioid receptors. What does this mean? In high doses, in very, very high doses, it is used actually to help opioid addicts break free of their addiction because it blocks the effects of the drug on their body. Well, that's not what we're talking about here. We're talking about very, very low dose. As opposed to 50 to 100 milligrams, we're talking about 3 to 4 milligrams. And in low doses, it is found to have a significant immunomodulatory effect, which means it decreases the immune response in the scalp. It's been successfully used to treat several types of immune disorders, such as Crohn's disease, fibromyalgia, regional pain syndromes, even multiple sclerosis. There are studies to show that it helps. Recently, off-label use of low-dose naltrexone has been shown to be useful in several dermatologic conditions, such as LPP, the lichen planopilaris, this scarring alopecia, as well as atopic dermatitis and gut-tape psoriasis. Our experience here, we've actually used a fair amount of it. We find that utilizing doses of 3 to 4 milligrams daily we've had excellent results in decreasing inflammation and then utilizing other medications such as minoxidil, and rarely PRP as well, but we do use laser to stimulate growth once the itching and the burning and the redness has diminished, and the low dose naltrexone helps that. Now, what about studies out there? There aren't a lot, and it's a relatively new treatment program. Studies utilizing low dose naltrexone in the treatment of scarring alopecia have shown mixed results looking back. However, more recently in the last year or two, we're seeing more and more research being done. There was one study just last year where a patient didn't respond to the usual treatments, and her physician decided to try low dose naltrexone plus PRP, which I'm sure many of you are familiar with. And she had significant regrowth and reversal of her disease. So I think it has, there's usefulness here. Whether it's not likely to be a standalone treatment, it's probably going to need to be used with other treatments as well, but it's incredibly well tolerated. The side effect profile, again, you have to look at these percentages with a little bit of an open mind. Vivid dreams, 37%, headache, 16%, nausea, upset stomach, 16%, insomnia, 16%. What we find is very few patients actually have to stop it. Sometimes we'll cut the dose down. The dreams, it tends to resolve over time. And again, if we cut the dose back a little bit, that usually will take care of it. So it is very, very well tolerated. The studies that I reviewed, which reviewed in great detail side effect profiles of using low dose naltrexone, found that they were, even though some of these side effects were listed, very rarely, much like the other medications we mentioned, very rarely does it require the patient to stop the medication. There tends to be a tolerance. Like in a lot of medications that we take for a lot of different reasons, our bodies sort of develop a tolerance to the side effects. It's not like you're just getting used to them. They actually subside or get significantly less. This other medication, hydroxychloroquine, has been used for a while for scarring alopecias. It's actually an anti-malarial drug, but it also has some anti-lymphocytic effects, so it does decrease inflammation. For many years, it was considered first-line therapy. This particular review in 2019 showed that utilizing it just as monotherapy, use just hydroxychloroquine alone, up to 74% of patients had improvement. It required up to a year's therapy for that to work. However, much like all of these treatments for hair loss, almost regardless of what the cause is, the benefit will only last while you're on this medication. Hydroxychloroquine does have some significant side effects, and the most important ones I put down at the bottom. Some, GI effects, fatigue, a little bit of a rash, generally not that bad, but elevated liver enzymes, again, can be a side effect of this medication, and it needs to be monitored. And rarely retinopathy, which is eye pathology, can occur. It requires an ophthalmology exam prior to starting treatment and periodic checkups. There's some debate out there. I actually saw two different reviews of side effects of hydroxychloroquine. One group in Boston actually felt that the side effect profile was safe enough to consider using this fairly regularly. A different group in New York had a different viewpoint on it and felt that they were seeing more significant side effects. But regardless, this would be something that someone who is very familiar with this medication and does take care of a lot of scarring alopecia patients, those are the people who would use it and would follow these patients carefully. Again, usually in conjunction with other therapy. Doxycycline is an antibiotic. However, it also amazingly has some anti-inflammatory properties. Again, we always use it with other medications when we're treating people for scarring alopecia. The most common side effects are GI side effects and some skin eruptions and photosensitivity. It makes you more likely to get sunburn. For those of us who are incredibly pale, that can be a problem. Again, the percentage of people who have to discontinue it because of side effects is pretty small. I'm just mentioning prednisone real quick. It's a strong oral anti-inflammatory. It can only be used for short periods of time, several weeks, in patients who are experiencing specific situations for scarring alopecia or alopecia areata, when you have this sudden huge shedding of hair, you know the diagnosis, but it's just unrelenting, and it can be frightening. And in those patients, we might give them a short course of high dose prednisone, and it will slow the shedding down while we wait for some other treatments to finally kick in. So, but it's not typically a medication that we would use for any type of hair loss for any length of time. It's really just short term for those extreme situations. Future treatments, I'm going to just, again, I'm going to go through these not in great detail. The JAK inhibitors are very new and exciting for alopecia areata, just recently approved by the FDA, and are now being tried out with scarring alopecias. Then I'm just going to talk very briefly about some newer testosterone blockers that are coming down the pike. So JAK inhibitors for alopecia areata. Alopecia areata is a non-scarring autoimmune disorder. And when I say non-scarring, it's interesting, you know, people lose so much hair, but yet their hair follicles are still intact, which gives hope because it means you can bring them back. Once in scarring alopecia, if it goes on for too long, the hair follicles actually are destroyed and you don't get regrowth if it's not treated aggressively early. The incidence of alopecia areata is about 2% of the general population. It kind of waxes and wanes, it comes and goes. Most people, so up to 50% of people who have their first episode, which is generally a small spot, it will go away with no treatment. However, I personally wouldn't wait for that to happen because you just don't know if that's going to happen. And but then, because again, you could be in the other half of this group that it progresses and you don't want that to happen. It can progress to total loss of scalp hair. That's about 25% of patients that will happen. That's called totalis, or total body hair loss, which is called universalis, which is, again, totalis universalis is so traumatic for women and men. I'm not going to discount the effect that it has on men, but the effects on women, I think, are stronger and deeper. Emotionally devastating for many women who suffer with this disease. So baricitinib is the JAK inhibitor that I'm talking about. In 2023, it was the first medication, oral medication, to be approved by the FDA for treatment of alopecia areata. Now, you might say, well, what about all these other medications that I mentioned? Well, interestingly enough, virtually all of those other medications are not FDA approved just specifically for alopecia areata or any kinds of alopecia. They are off-label, which is not uncommon. As physicians and clinicians, we use medications for off-label all the time. But for something to be FDA approved for a specific disease entity, it has to go through, as a new drug, has to go through incredibly stiff testing. So this went through different levels of testing over many years, and it was finally approved. And it was very exciting when that happened. And initially, everybody thought, well, this will be a game changer, and it is, but we have to keep in mind that it was tested really only in patients with severe alopecia areata, and I'll let you know why that is in a minute. And up to those severe patients, about 38% responded significantly after 36 weeks. And you'd say, well, it's only 38%, but there really is nothing else that has this type of response for alopecia areata. That's how difficult it is to treat this disease. Again, it only works while you take it. It's hard because these women and men would get benefit, and they would get, this 38% would get significant regrowth. Some would have total regrowth. But the question is, and there's no answer to this yet, is long-term. We're talking about years and years and years. Can these drugs be taken forever? And we don't know the answer to that because it only works while taking it. For many of these patients, as you start to taper, their hair starts to fall out. And if they come off of it, they unfortunately will oftentimes relapse, if not immediately, but within a year. So these are patients who have severe alopecia areata. And for those patients that respond, it is exciting and thrilling. They're just so happy about it. But again, we're new with this medication. It's going to take some time to sort of sort out the long-term effects. It does have some side effects. The adverse events included elevated lipids, like your cholesterol. Your LDL will go up. Elevated CPK, which is a muscle enzyme, can cause some inflammation there. Liver enzymes can also go up. It can cause some blood count changes, some low white blood count, and rarely people have been found to have myocardial infarction. Whether that's related to the lipid issue or other issues, it's unclear. Also of significance is this entire category of medications, the JAK inhibitors, do cause an increased rate of infections, particularly upper and lower respiratory tracts, urinary tract infections, as well as skin infections known as cellulitis. So it's not without some risks, and that's where some of the limitations are. I'm going to just go back and say again, I just want to say for patients with severe alopecia areata, this is a game changer for them. And again, the unanswered questions yet about long-term, what does this mean? The studies went on for about a year. People have not yet been followed longer than that on this particular medication. So we're hopeful for these patients that have severe alopecia areata that they will be able to take this medication for a longer time. And I'm just briefly going to talk, actually, all I'm going to say is for new testosterone blockers, there's nothing right now that I can find that's being tested that is oral. These are all topical treatments. I don't know if they're going to replace the ones that we already have. So unfortunately, we don't have anything in that group. So I just want to thank you all. I am going to open up the question and answers for both myself and Kim. Again, so far we only have 10 questions, so we'll probably get to all of them. But if I don't answer your question, or if you think of something later and you want it answered, just send it to us at info@meditrust.com. I'm going to bring myself back. Maybe. Yep, here I am. Okay. And Kim is back as well. So I'm going to open up the questions. And I'm going to give this to Kim. Anything on oral minoxidil, I'm going to hand over to Kim, and it looks like a lot of them are. So oh, actually, this is interesting. Can topical minoxidil cause the same kind of hair growth as oral? And is there a way to avoid that?
Oh, repeat the question one more time.
It's, can topical minoxidil cause the facial hair growth like oral does? And can it be avoided with the oral and the topical minoxidil, avoiding the facial hair growth?
The oral actually does have higher levels of minoxidil in your bloodstream. Like, so you will get, I think, a better response than topical. The thing is if you are blocking anti-androgens, like using Spironolactone or Finasteride or Dutasteride, you can actually block a lot of that facial hair also. So blocking it, you could use one of the anti-androgens.
Oh, okay. I'm just going to add to that studies have shown that the medication I mentioned, the bicalutamide, actually does decrease the facial hair growth that's caused by minoxidil. Next question, like oral minoxidil, should topical minoxidil be avoided with patients who have cardiovascular disease?
No.
Yeah.
No, there's no blood pressure effect.
Yeah. The absorption of topical minoxidil doesn't reach the same levels as taking it orally. And so the side effect profile is significantly safer. But again, in most patients who are taking it orally, they can handle the oral dosing. It's really interesting. The patients that I've been most reluctant with oral minoxidil are a lot of times these very small women who are thin and have borderline low blood pressure to begin with, and I'm always a little reluctant, and I start them incredibly low dose, and I'm amazed at how well they tolerate the oral. I have yet to have to stop it. So if you start really, really low and kind of work your way up slowly, they seem to be able to handle it. Somebody had a question about laser therapy. I'm actually going to, if you could send that to info at meditrust.com, I have more specific information for you. So the question about the laser band, the different caps, if you could just send that message to me via info@meditrust.com, I will give you some very specific information about that. This is a great question. Does insurance ever cover hair loss treatment specifically for frontal fibrosing alopecia? And the answer to that question is they cover some of it. They will cover medications, biopsies, and some follow-up. What they don't cover is if you need, and we do use laser therapy. We recommend it for scarring because it has a strong anti-inflammatory benefit. They won't pay for laser. They won't pay for PRP if the scarring is under control and we really want to strongly stimulate regrowth. Sometimes we do PRP and get some good result. Like that one study that I mentioned, your insurance will not cover that. So it is very frustrating. And honestly, the laser and the PRP are not inexpensive. And, I have a young patient who actually had cancer as a child, and she has significant loss, and she's had PRP and laser, and she's on some medications as well. And she's actually sending letters. She has a campaign going where she's trying to get all of her treatments covered by her insurance, because thus far they have refused. So even under those circumstances, scarring alopecia, alopecia areata, PRP, laser, those things are not covered. One woman asks, she's had borderline high potassium a few times. Would I still consider spironolactone? That's a really good question. Probably not. It depends on how high it got, because you'd have to be monitored really, really carefully. And spironolactone that, I used in my medical practice, as I mentioned, for high blood pressure or for swelling or edema, those doses are much lower than what is required for hair loss. So if you're already somebody who has a borderline potassium, to use those high levels of spironolactone, I don't think I would recommend it. And she asked, is there a stronger response with spironolactone than oral minoxidil? No, I don't believe that's true. I think oral minoxidil in the right patient can be a really good response. And Kim mentioned briefly about the fact that there are some women who just don't respond to topical minoxidil as well. Our bodies are different. We process the drug differently. And there about 50% of people, it takes a higher dose of minoxidil for it to be beneficial. And so we do know that it will work better. So I would probably not take the spironolactone, given your history of high potassium. You're 64 years old, your testosterone levels are probably lower anyway. I think oral minoxidil, given if there's no cardiovascular disease, if your blood pressure is fine, I think that's a safer alternative. Is naltrexone typically covered by insurance for scarring alopecia? Sometimes. I hate to be vague. Again, everybody's insurance is different. Hydroxychloroquine, doxycycline, finasteride are covered. I guess you're already on those. What the naltrexone might add for you, naltrexone is really good at decreasing the symptoms. That's the one thing that studies mentioned, and I should have mentioned that. The burning, the itching, the scaling, even if you don't have a big difference in terms of inflammation, it actually seems to help in some patients with the symptoms. So it might be worth considering. I don't know how long you've been on these medications for. In truth, it takes at least 6 months, preferably more likely closer to a year, for all of these medications to really have benefit. So I don't know how long you've been on them. It may be that it's taking a little bit longer. The other thing, and again, unfortunately not covered by insurance, is to consider is laser therapy. And that you can get some laser therapy. There's a wide variety of cost, and you can get benefit even on some of the lower cost lasers, and it does have anti-inflammatory benefits. So here at MediTrust, we don't just rely on medications. We utilize laser therapy and naltrexone. So again, I don't know if that answers your question. I think it might help with some of your symptoms if you're not getting benefit from the standard treatment, which unfortunately happens. Okay, somebody asked, if you're having good response over many years, 3+ with PRP, laser, Nutrafol, and topical minoxidil, would you recommend adding any of the oral drugs? Her diagnosis is androgenic alopecia. If you've got good result, I would stick with it. If you think there's room for more benefit, if you want, the only thing that I might consider, I mean, if you're getting good result with topical minoxidil, you might get a little bit more with oral, but you're stating that you've had good response over many years. I would stick with what you're doing. And the important part is maintenance. You've got to keep at it. None of these entities get cured with treatment, they get treated. And so you need to stick with them. If you've been good with it for 3 years, I would stick with those. I don't know that I would necessarily, you're doing everything, you're doing great. Somebody asked, can frontal fibrosing alopecia manifest more on one side of the scalp? It can. It's not always symmetric. FFA, it tends to be sort of more of the whole area. There can be patchiness behind it. There sometimes is sort of a combination of FFA plus the LPP. So it can be a little bit asymmetric. But if I'm not sure if you're being treated for the FFA, your question wasn't clear on that. But if you're concerned, then have your scalp examined. It has to see scarring alopecias, you have to use trichoscopy. Scarring alopecias can be invisible to the naked eye. And so sometimes we only see it under the trichoscopy. If the trichoscopy is not done, then you cannot be certain that your diagnosis is correct. Are there oral medications that can use for a finite period of time? And the answer is, as I said before, these medications only work while you use them. If you stop them, even with the alopecia areata and the newer JAK inhibitors, you stop them, they generally go into relapse. And so it's frustrating, and there really is no finite time frame. It really is however long you need to use them to keep your hair growing. It's 8:06. There's a lot of questions here. I'm gonna do a few more for another few minutes, but then we are going to probably stop. So again, for those women that we don't get to your question, please send it to me at info@meditrust.com, and I promise you I will review them all and get back to you within a reasonable time frame. I'm going to throw this question to Kim. What is the success rate for oral versus topical minoxidil? I don't know if
I think you have to really look at the other modalities of treatment. I feel that, I've had great success with low light laser and oral minoxidil, fantastic results. Again, I think it's more about pairing and synergistic effects of your other treatments.
Yeah. This is a great question. I'm so glad somebody brought this up. In a previous seminar, I did mention that Finasteride, there was some concerns about breast cancer survivors. And that's a really good question. And multiple studies were done with Spironolactone, because again, for a long time, Spironolactone there was some concern that it might increase the risk of breast recurrence. And multiple studies have shown that that's not the case. And in fact, the oncologists are telling us that it's safe to use in breast cancer survivors who are experiencing hair loss. The Finasterides, it's not clear yet, and I would not recommend it for a breast cancer survivor at this point. Maybe that will change in the future if more studies are done, but I will tell you Spironolactone seems to be safe, but Finasteride, it's still unanswered. Question, is PRP and low-level laser therapy good treatment without using oral minoxidil? They're good. They're great treatments, but again, do I think that you're missing out on an additional stimulation of growth? Yes, I do, because they all work differently. They work differently. They work synergistically, but they work differently to get the best possible result. And it's like someone who has hypertension, and sometimes it takes 2 or 3 different medications to get them under control. They work differently to get the best result. But again, PRP and laser therapy, excellent treatments. We just like to encourage more. It's because we know it works better. And the more that you do, the better. Are there certain products, ingredients that should be avoided if you have scarring alopecia? The answer to that question is yes. And what I'm going to ask you to do is to email me again at info@meditrust.com, and I will forward you my list, because I do have a list. again, it's not proof that these products cause scarring, but these are products that have a history of creating inflammation. And since we don't know what causes that inflammation on the scalp, we really encourage women who have scarring alopecia to kind of stay away from those. Okay, a couple more questions and then we're going to have to stop. Do any of these medications work for eyebrows and eyelashes? People who have loss of eyebrows with scarring alopecia, sometimes they will get regrowth with treatment for their scarring. But if you want longer eyelashes and eyebrows, you want to use Latisse, which work very well to get the eyebrows and eyelashes to come back. It's hard with patients with alopecia areata, but they do still help. Patients with scarring alopecia, they do tend to help. Latisse is a medication which does stimulate eyebrows and eyelashes to grow better. And two more questions and I'm done. If you take oral minoxidil successfully, can you ever stop it without losing your hair again? You cannot stop it. It's not a cure. It's not a cure. It's a treatment. And then oral minoxidil, can facial hair growth be reversed? If you're going to take the medication and you're getting some facial hair growth, you need to, I say the same thing to my patients that Kim just said. If your hair is growing on your face, it's probably growing on your head. Treat this cosmetically. Your focus is your hair. It's helping your hair grow better. Treat this cosmetically, whether it's laser or microblading or microplaning, whatever you need to do. Because again, I've only seen one patient whose facial hair was so bad that I really needed to stop the medication, and that's 1 out of 1,000. So usually it's not so bad. I mean, I've been using minoxidil for over a decade. I have a lot of peach fuzzy kind of hair. I have had some of it lasered off. I use microblading. I just deal with it, and I'm happy that it's working on my head. So anyway, yes, somebody's asked about the recording. This webinar will be on our website, not tomorrow or the next day, but it will be I would say within a week. We download it, and it should be available for everybody to look at. Oh, I'm going to answer this question. Is minoxidil safe during pregnancy? No. So if you're actively trying to get pregnant, get off the minoxidil. The good news is during pregnancy, your hair will get thicker, it will be happier, you will love your hair, but you cannot take it during pregnancy. So anyway, thank you all so much for coming and for your questions. Again, there's a bunch more questions, and I am very, very happy to answer them all if you forward them to me. A lot of them are excellent questions. Yeah, I wish I had time to answer them all. But anyway, info@meditrust.com. Please send these questions if I haven't answered them to your satisfaction or if I didn't get to them at all. So I'm just again going to say thank you all for joining us. I'm always so happy to see so many people looking for help with their hair loss. We are here. We love what we do. We do care about our patients, and if you have any questions, just send them on over, and we'll be happy to answer. And again, the other thing that I would say is if you have ideas about what you want us to talk about, future topics for webinars, we're very open to new topics. So thank you all. Thank you, Kim, so much. I appreciate it.
Thank you.
Okay, good night, everybody.
Good night.